get started here, just kind of repeating a few things from last week. Just the SAMHSA disclaimer, and you will get all these slides after the workshop. I believe they'll be sent out tomorrow. Just a reminder to kind of be patient with each other and, as far as language, and kind of try to, focus on kind of people first, non-stigmatizing language. And, feel free to use the chat. Please do throughout this workshop today. And, you're welcome to raise your hand to speak if you're in a place where you can do that, and just be conscientious about sharing airtime and kind of giving other people a chance to speak too. So again, just repeating that the goal here is kind of really to explore how to build bridges between harm reduction and treatment as part of the continuum of care for people with substance use disorders. And so today we're going to focus on kind of ways to strengthen those connections between harm reduction and treatment services, and also how treatment providers are incorporating harm reduction into their work. So I was looking for some graphics here. Sometimes we talk about a continuum of substance use, and I'm going to show a few different options here. And, anybody who's seen other versions, I'd welcome I'm starting a little collection here. But, really, I'm sure you've seen variations on this, types of substance use, kind of ranging from no use through experimental, social, or occasional use. This was one that kind of popped up in this example, using as required, in terms of medication, and then moving into harmful use or dependence, or addiction. A lot of the ones that I found came from Canada, actually. And, this one kind of notes that people don't automatically move along the continuum, and people can be at different places with different substances here. I liked this graphic on the left just because, interested in drawings and, people kind of represented from the perspective of, this person is using I. So, I think this is used more with a young adult or student population, kind of circling around there from, this idea of experimental might be different than social use, regular use, kind of introducing the idea of problematic or harmful use and dependent use. And, I think important to think about when we think about substance use disorders, that it's, depending on what graphic you look at, it's moving into that problematic or harmful use or dependent use. So one other thing to kind of think about is sort of, if you're thinking about this continuum or these different types of substance use, then kind of the population of people who you might think about benefiting from harm reduction may be different than the population, or is different than the population who might be targeted for treatment. So, just kind of going back along here, I think historically maybe harm reduction wasn't necessarily, because of differences in the drug supply, thought to be something that you would try to introduce to someone doing social or occasional use, as much as someone who's kind of using more consistently, or using certain types of substances or certain types of behaviors such as injection. But I think now, for the purpose of treatment, what we're really focusing on is this kind of right end here, or kind of on the left side graphic here. Yeah, and Carol, that's a great point, just that use changes over time, it can shift based on incomes and benefits payments, where people are kind of changing their patterns. Please feel free to add any thoughts about that, or raise your hand, just as far as, and if there are graphics you use, feel free to share those either via email afterwards or post links in the chat. So this question, I'm kind of hoping everybody will sort of use the chat to answer this, because I think when we talk about treatment, sometimes there can be people would put a different set of services on that menu. So, I would just ask everybody to, free associate a little bit. Doesn't have to be comprehensive. This was another thing I was looking for graphics, but, if you were to create a menu of services, with treatment options for people specifically with substance use disorders. So, more towards the end of harmful or problematic use or dependence, what would you put on that? And if you prefer to kind of share, I guess I'd say, maybe give everybody a chance to post in the chat. So seeing medication, residential outpatient, vocational educational services, again, medication, methadone, buprenorphine, mobile treatment, full continuum of harm reduction treatment, recovery support, case management, residential detoxification, safe drug supply and injection equipment, training on safe injection practices, acupuncture, mindful movement, supportive services like housing, food, trauma-informed care, mental health, emergency issues, comorbidity support. So that could be mental health, it could be, medical needs, dental sometimes gets overlooked in our fractured system of care, but really important for a lot of people, especially as, they're seeking help. So feel free to add to that. So I actually didn't find yoga. That's a great one. Family support, thank you. So this is kind of what I came up with. So, thinking about what's offered or what's missing and trying to categorize different things. Now, this is not meant to be comprehensive. Sometimes when you're doing things on Zoom too, you're trying to make sure you're not overwhelming information on one slide here. But I tried to think about kind of what fits under that category of counseling and mental health care. So group therapy, individual therapy, family therapy, case management, peer support, and mutual aid. If you had a graphic, all things that kind of involve, that interpersonal interaction. Some of it might be kind of with more people with professional training or licenses, others kind of peer support and mutual aid of different sorts, a different type of what some people would consider counseling. In the middle, thinking about the range of medications. So those might be provided during a detox or withdrawal services. Many that have been mentioned, methadone, Suboxone, Vivitrol, naloxone could be put in there, other psychiatric medications, mixing that with medical care, thinking about treatment, also including Hep C and HIV testing and treatment, wound care, and then other medical and dental care. And then a lot of the wraparound services. Yeah, so STD, or sometimes referred to as STI testing. So then, whether you would put wraparound services as part of treatment or part of the continuum of care, kind of in recovery support, legal aid, really critical, housing help, employment assistance, educational programs, and benefits navigation. Now, again, this is kind of not an exhaustive list here, but I was really surprised that, oftentimes, and I'm going to show in the next graphic, I'll come back to this one, but even, with the National Survey on Drug Use and Health, we think about treatment in terms of venues or locations as opposed to a menu of services. And, sometimes I think that can take away from asking, well, so what's offered as part of intensive outpatient, or what's part of residential? So this was sort of my stab, and kind of welcome thoughts on that, to think about it more as a menu, and what would change if people were presented with kind of a menu and were able to select what worked for them at a certain point in time, and might have to go to different places, ideally could get services in one place. Any thoughts on kind of thinking about the difference between considering treatment based on the services offered versus the location? Feel free to use the chat or raise your hand, or if you want to just unmute. Is that a different way to think about it for any of you? Or have you ever seen graphics that you think present sort of a menu of treatment options? Okay, well, I welcome any other thoughts on that or feedback. As Carol's pointing out, putting things under one roof. Jason is adding, that the Society for Addiction Medicine has been encouraging the unbundling of service and setting. So service and setting, that's a good way to think about it. Kelly, you want to unmute? Great.
My mentor always told me when I first started out that behavioral services and human services should never be office-based or chained to a specific clinic or brick and mortar facility, that a street level, person-centered, literal street side approach, specifically with this demographic, is usually the easiest way. I came up in this field doing street level, like street side research, resource mapping in areas based on socioeconomics. A lot of the time, we find that when we do chain resources or interventions to a specific building, that building is very specifically placed to invite a population and to have a barrier to a population. So when you think along the lines of stuff like redlining, you're going to see a desert of resources in, you know, more urban settings, as opposed to a surplus of facilities, clinics, agencies, grassroots, what have you, in more suburban settings. But then once you get rural again, then it's everything disappears. So I do think there's a lot of danger in having things be clinic or office based. A big part of my wraparound that I do is that I am free and encouraged to operate outside of the hospital that I work in.
Great, thank you. And, you know, so thinking about settings, just so you brought up a few things, is how accessible something is and how, you know, welcoming it might be, or, you know, if people are intimidated about a hospital setting. I've seen some examples in, you know, particularly in New Haven, of street medicine teams, you know, and as people get to know the teams that are going out, you know, then they might be more comfortable, you know, if they need higher level of care, specifically medical care, than going to a hospital or another clinic setting with someone they trust. Jeff?
Hello, everyone. I was also going to add, when you take the view outside of a setting rather than a menu of services, those services can be spread out through many groups that can provide them, and opens up more, I'll use, for the lack of a better term, slots. You know, how often do we hear when trying to work with people for getting them into treatment, there's no bed, there's no slot open, something like that? By looking at it more of a menu of services that many providers could work together to meet the individual's needs, that might open up the availability. You know, we all have limited resources, but it might be a little bit easier if we were able to spread it out rather than thinking of, you know, one program or one setting offering everything the individual needs.
Yeah, and I think that sort of was one of my entry points, is thinking about, you know, a lot of the harm reduction providers I've spent time with, and, you know, treatment, and then everything as far as wraparound services, that it's for the way things are set up and payment models, it's difficult for one organization to offer everything, even at the times that there's kind of, you know, can make it easier for people to at least be able to navigate that. And that's why kind of thinking about the topic of this workshop and building bridges is sort of, how can, you know, something might not be some organization's lane or priority, or, you know, what they're best at, but having relationships between different organizations. Carol?
Just playing devil's advocate on that. In my experience working with people who are actively using, the more barriers, the less likely they're going to follow through. And I've found that when it's only one place they have to go, as opposed to 5 or 6 to get services, the barriers are lowered. We're really looking, for me, the piece that can carry over from harm reduction into treatment is low threshold.
Yeah, and I think, you know, in thinking about this, it's not so much necessarily about fracturing services, but thinking about when research is done, when policy is done, when surveys is done, that treatment is kind of more clearly defined, you know, by what's meant by that, you know, so what's in that. And if something isn't considered treatment, but it's considered necessary. So someone might say, you know, legal aid isn't part of treatment or housing or employment, but for people moving along the continuum of care, you know, again, who have, you know, substance use disorders that kind of move into, you know, more complex needs, that that you're not forgetting all these other things, or they're not getting left behind because they're not kind of part of how, you know, the system of care looks at what's offered. Yeah, Jeff, multiple service providers can work in collaboration with one point of entry. And yeah, Kelly's saying, you know, often harm reduction groups, you know, right, handing out Narcan, doing sharps cleanup, distributing safe injection supplies, rapid STI, HIV, Hep C testing. And that's absolutely what I've seen. And, you know, kind of what inspired me was also thinking about places where I've seen that kind of those connections where, you know, those groups are also hosting days at a drop-in center where, you know, teams come in to do testing and treatment for, or testing for Hep C, HIV, and then link people to treatment, you know, provide counseling, and then offer medical, you know, kind of low barrier medical care, but then a pathway with a trusted kind of navigator or provider to get other care. So yeah, just kind of reiterating that, you know, in this survey, they don't actually look at what services people have received, you know, despite the survey been done many years, they're kind of looking at where the services happened. And, you know, I think it'd be helpful to know sort of what services are envisioned as being provided in these places, and then what else people are getting. So just kind of reiterating some things we talked about last week, you know, as far as the treatment gap, you know, so just that we all have heard this statistic that 10% of people with substance use disorders receive treatment, you know, keeping in mind these surveys invariably miss a lot of populations, you know, people who are incarcerated, and data collection was really kind of disrupted by the pandemic. There's a lot of people who achieve long-term stable recovery without formal treatment or specialized services. Again, there are debates about what's considered treatment, and how broadly that category is defined. And then many people need support beyond treatment. So, you know, I've said you could do a whole other workshop and a lot of research on the linkage between treatment and recovery support that would include a lot of those things like, you know, housing, education, employment, legal system issues, et cetera. But kind of in thinking about this gap, you know, one thing that I had noticed in sort of hearing often that, you know, focus on, you know, trying to move away from mandating or requiring treatment, and then on the other end, kind of waiting for someone to be ready for treatment. And, you know, what kind of comes up in that middle ground, you know, whether it's phrases like nudging, motivating, encouraging, incentivizing, facilitating, that, you know, there can be a lot that happens in between, you know, these two poles. And sometimes, you know, particularly lately, like things can end up in these kind of binaries where, you know, a lot of kind of room for discussion of what could happen in the middle. And just to kind of think about nudging as a term, you know, this is something for anybody who's kind of been through a public health program, you know, comes up as, you know, something that's done in public health and kind of talked about, whether it's calorie counts on menus, cigarette taxes, smoking bans, vaccine clinics, helmet laws, or soda size restrictions, you know, thinking about ways that policy or services can kind of nudge people to a different behavior. And this book, Why Nudge, you know, Cass Sunstein is kind of well known for some of this work and describes nudges as initiatives that maintain freedom of choice while also steering people's decisions in the right direction as judged by people themselves. So I think for a lot of people working in this field that, you know, kind of letting that be a person-centered, you know, driven by an individual. But really the nudge can be an interesting concept to think about. And this was another essay, I kind of adapted these questions on the left, is that when you really start breaking down, you know, okay, what does that mean? And, you know, who do we nudge? People who misuse substances, or do you focus on people with addictions for that kind of nudging, particularly when you're talking about treatment? You know, when do you nudge? After an overdose, before an arrest, when someone is coming to pick up syringes and supplies. All these are touch points that, different nudges could be happening and often are happening. What are you trying to nudge? Is it changing substance use behaviors, encouraging someone to consider treatment? Where does that happen? In a courtroom, a doctor or counselor's office, an SSP, again, these are not ideal or recommended locations, but places where traditionally we've kind of seen, levers that kind of try to get people thinking about or moving toward treatment. How do we nudge? Peer support, obviously growing, removing barriers to getting help is a big way, making treatment more appealing. Yes, Anita, everybody will get these slides. And then why do we nudge? Because sometimes in public health, the nudging can be about achieving public health goals, which is reducing overdose deaths predominantly right now, improving health behaviors, reducing harm. But you could have a lot of conversations about kind of what the goals are, with this. So, the link is into this longer essay. It wasn't particularly about substance use, but I thought had kind of some provocative questions to ask. Any thoughts on that? John?
Yeah, I'm curious on the how do we, well, basically all of it, but how do we nudge? Why we're not using like the educational system?
Mm-hmm. I
You
think
could be teaching these. I mean, they already teach about drugs in schools now, but it seems like the more they teach about it, the more the kids want to go out and use it to see if they're telling the truth.
I've more experience in a college and kind of university setting, and it was surprising to me, how little kind of this topic was discussed or addressed in terms of both kind of harm reduction tools, support groups, motivational interviewing. There are places where there are great programs on campuses, but a lot of places where it's kind of not happening. And I think a lot of, higher education doesn't necessarily want to hear about this issue because then they have to address this issue. But I do think that's kind of starting to change. Kelly?
This really reminds me a lot of William Lefquist. He's does a lot of work. His book is called Discovering the Meaning of Prevention. And it's called The Spectrum of Attitudes, which is very similar to this, where you can treat people as objects, as recipients, or as resources. And, when we see people being treated as objects, that's very much the mandated court system, where you're mandated to some arbitrary level of treatment that people have decided for you. There's recipient, which is kind of like giving this patronizing, I'll make the best choice, but don't worry, you're going to be happy with it. And then there's resource, which is the fundamental of what harm reduction is, I think, to me at least. But I think a bigger part of this also is that I think that there just needs to be like a field-wise divestment from the idea that abstinence and recovery are mutually exclusive. Because I think when we put ourselves in that binary and we treat harm reduction as a way to shepherd someone into abstinence, that's costing lives, because a lot of people just simply don't want to be abstinent. And if that is what, harm reduction is its own pathway. So, nudging in a motivationally interviewing way, super important, huge part of the peer toolkit. I do it a lot, but still in a way that is treating that person as the best expert on their own experience. We say like the answers are in the room and I don't have them.
Yeah, I think, so you mentioned you're sort of leading into one of my next questions. So I don't think this is necessarily, well, it's definitely not about a binary, that has abstinence at one side. It's really just about thinking that often people express in many of these service environments a desire to change or an unhappiness with their current situation. So, this is more broadly a nudging of like getting someone to, having those conversations about help or services or support. Often it might be treatment, but not necessarily. So, nudging is just something between forcing and waiting, really broadly and really generically. Deborah?
Yes, hello, everybody. I just wanted to add that I think that better informing and equipping the faculty and staff in schools and in the workplaces to spot someone that's in distress, especially in our schools and on our university campuses. Just better equipping our staff and faculty to recognize it. Maybe teaching some more de-escalation, often de-escalation and, just how to respond in a immediate crisis would help us all as well.
Yeah, and I think if anybody saw the news of the CDC report that came out, particularly, adolescents and kind of, I think focused on data on girls and kind of, mental health crises and suicide. And I think they're particularly coming out of the pandemic, there's a lot more focus on, that population and just broadly mental health issues that overlap with substance use. So, Kelly, you kind of mentioned one of the things that answers this question, but, thinking about sort of what tools and services can help motivate, incentivize, and facilitate treatment participation, what are some of the kind of practices, particularly those of you who do work in treatment settings, that kind of come to mind that work for these conversations? Or that you've heard about? Did someone start there?
I did. I'm trying to raise my hand. There we go.
Oh, that's okay.
Okay.
Thanks, Kelly.
There's a whole model of treatment that's contingency management, which incentivizes people in treatment. That could be applied to getting people into treatment as well. As long as, and this is always the caveat, that the incentives are meaningful to the people receiving them. But, money speaks, and particularly with people who are living on the edge. And if you look at it from the public health model and take a step back and say, it's worth spending this money to get someone to go into treatment because in the long run, it'll be a lesser burden on the public health system. It makes sense, but it also makes sense just from a human point of view.
And I'm going to talk about that in a little bit. So thank you for mentioning contingency management. Deborah?
Yes, one thing that our organization is looking into doing, Susan, is partnering our youth with our seniors. This is something I'm going to do in the organization because I noticed that it has worked well within our faith communities. To partner the youth and the seniors and have them to mentor one another. And that helps to facilitate more participation. Excuse me, I have some oral issues going on.
Thank you. That's a really great point. And if there's anything you want to add in the chat, just as examples of programs or services, I think I've definitely seen kind of more examples, both kind of peer support and utilizing peers, but then also kind of partnering with the faith community as a partner. We saw that was very effective, with vaccine rollouts too. So, can be part of that spectrum. John has added in the chat, nudging could be like a switch. Too much just turns those you're nudging to turn off, which is a good point. I'm going to come back, Kelly, but just wanted to, you brought up motivational interviewing. So hold that thought. And then just because I think some people might want to catch up here. So these are some tools that, have been mentioned so far, but links for those of you who haven't had trainings in these or heard about them to kind of find out more. I learned about motivational interviewing a few years ago. I find it really fascinating, you know, not just in conversations about substance use, but just behavior change and this idea of, you know, positive reinforcement and helping strengthen a person's own motivation and commitment to change. So if you've never done a training on that, I really highly recommend it. Contingency management. So Carol brought that up, and I can just add that, you know, I am aware of more of an experiment that's going to be happening in California to loosen some of the regulations that would limit using, you know, the amount that can be given to people. You know, contingency management is often used with people with stimulant use disorders, you know, where medications are not an option, and, you know, is very evidence-based. And, you know, one of the questions I asked when I was in a workshop about it is, well, with these small rewards that, you know, may be monetary, do they work, you know, for different demographics, you know, so for higher income people as well? And what I was told is that, you know, the research, at least what's been done, shows that, you know, even a small reward can be very motivating for people, you know, regardless of financial need. But the idea might be a prize or a voucher, you know, that maintains someone in treatment, and, you know, often happens in a group setting. So people are also kind of encouraging each other. Peer support, many of you kind of come from that background or work with peers, you know, people with lived experience with substance use disorders. This is a long history in mental health care as well, offering guidance and support to help others achieve their goals. So I think, you know, people in those roles are often a really, you know, helpful conduit for other people to trust and maybe consider behavior changes or trying treatment, who otherwise, you know, would not go down that path. And then screening, brief intervention, and referral to treatment, you know, you could kind of think about that as also a form of, you know, nudging, you know, conversations. Many of you probably have been to a primary care doctor and maybe cursorily, you know, asked about substance use. Most of us only have 15-minute appointments in that setting, but, you know, there's starting to be a little more focus on where these screenings are happening, you know, and how they can be brought to other locations and kind of identify if someone has a problem or would consider treatment. So those are sort of the, you know, what you could say are sort of those positive, you know, motivating, facilitating levers. There's also just that kind of removing barriers to care. So we talked about some of this last week, and this is not an exhaustive list, but, you know, making treatment more appealing is obviously, you know, you need to remove the barriers that hold a lot of people back. So, you know, offering treatment on demand, navigating insurance coverage and payment hurdles, helping with transportation to services. So that's a huge one where, you know, particularly in rural communities, for people to be able to get to appointments. Offering person-centered, culturally sensitive care. We'll talk a little bit more about that. And then reducing regulatory hurdles that can limit treatment access. So, you know, seeing some changes both on, you know, for buprenorphine and methadone, kind of in the methadone at least kind of being proposed, but a lot has come out of the pandemic that, you know, have relaxed some of those restrictions that have started to kind of open up treatment. Any other, sorry if I just adjust that, thoughts about removing barriers here? So feel free to kind of add to the chat. So one venue, and this is, you know, just one that kind of gets talked about, that I wanted to kind of, I had started down a path of kind of looking into some research, you know, based on seeing that people who use syringe service programs, which we talked about last week, are 5 times more likely to enter drug treatment and about 3 times more likely to stop using drugs than those who don't use the programs. So this, most of the references, you know, whether you see them on social media or often in news coverage, you know, point to the CDC page. So again, you'll get this link where you can look at some of the other research. And, this seems to be the main study that that page at least lists, and a lot of other people cite in their own research. And, kind of looking at it a little more kind of in depth, you can kind of see that this was a very specific population that was looked at, in Seattle, late 1990s, kind of looking at a methadone program. There are other studies that are listed on that page and kind of a little bit more that's been done. But basically what they found, and Kelly, I'll come back here, is that, looking at kind of retention and methadone programs among people in Seattle who were injection drug users, people who had previously used the exchange were more likely than people who had never used it to report a drop in injection and to stop injecting altogether, as well as to remain in treatment. And again, this is specifically for methadone treatment at the time. And new users were 5 times more likely to enter drug treatment than people who had never been there. So there's been a little more work done on kind of, new users of these services versus existing users, and sort of where that point might happen. That some research has shown that people, who are kind of new have, in the intake process, possibly kind of more motivation to talk about treatment options. But this is definitely an area that there could be some more research to look at, what's happening in that pathway. Kelly?
So safe consumption is my specialty.
Mhm.
I am a IV drug user in recovery. I've been in
Mhm.
sustained remission for almost 8 years, and I was a patient of the local syringe exchange program. And it wasn't a sanctioned injection facility in the political governmental insurance liability way, but it was kind of unspoken that, like, once you got your clean works, if you were really, really sick, there would probably be a bathroom that you could go in if you left the door unlocked, that kind of a thing. But that syringe exchange was the first place that I felt human in like 10 years. I started using when I'm 32. I started using when I was 13, and I was injecting by 18. And having a place that I went in where, like, the least interesting thing about me was that I was an addict there to get clean needles. It was more about, like, did you eat today? Hey, you want to take a quick shower? We've got some clean socks for you. Just like having my humanity reaffirmed when it wasn't something that had occurred to me in a very, very long time. And so as I grew more familiar and they grew to know me more, I was more willing to believe that a person like me deserved something like treatment, or not putting holes in myself and switching to insufflation or inhalation or smoking, doing something that was less physically traumatic to myself than, poking my arms full of holes 10 times a day. And Seattle is making a lot of really great waves, but I think it's, in this country, we don't have to fully invent the wheel. We can just simply look to, like, Swiss foreign policy on 4-pillar model, or simply look at places like Vancouver and Canada, because they have been to great success utilizing this kind of like public policy around drug use and misuse and safe consumption, because people are always going to use drugs. People have been using, misusing, and overusing substances since man-made wine. Like, this isn't a war that I think is going to be won. But when, I believe it was Carol was talking about, when it comes to public health, well, I gave a lecture a couple months ago. It's something like $14 million could be saved in about a 5-year span in hospital cost. And when it comes to cost effectiveness, in terms of like ED utilization is going down, all of that stuff. So I think if we're talking about incentivizing people, let's incentivize the medical field and insurance companies to change the admission parameters. Let's incentivize them to actually accept these patients with these medically complex cases and all of these comorbidities and these behavioral concerns. We do enough of the work, and, using people do enough of the work to survive to the next day. The damn hospital can do a little bit of work too, and, open their doors a bit wider when it comes to stuff like stigma. Cut that shit out. You know what I mean? You guys are here to sustain life. Sustain it. Here we are.
Thanks for sharing that. I apologize if I didn't notice if you were with us last week. So we talked about On Point, and I'm going to share a couple examples of other SSPs in a minute here. And if you weren't with us last week, you will get those slides too. So, so I think, part of it is facilitating these relationships and kind of this discussion too. There's kind of a range of people from different backgrounds in this workshop today. So thinking about, opportunities for better research or more research, is definitely, one thing that might kind of come out of this discussion. And then how these relationships kind of can be built. So, this is a newer study by someone that, I know here working in New York. Noah Kravchik and her colleagues, had kind of looked at a range of programs and interviewed, about a little over 500 clients attending a number of programs, both SSPs who were not offering, any medications for opioid use disorder, programs that were only treatment programs offering medication, and then some programs that were offering both, and kind of, basically found that, the range of programs that they were looking at were kind of not meeting the broader service needs of people who use drugs, and, recommending kind of investing in models that empower clients and integrate a range of accessible and flexible treatment, harm reductions, and social services, as a way to kind of pave the way for a more effective, equitable system. So really, this is just kind of, a small fraction of the research that I had found, kind of trying to understand, what's happening in this specific pathway. It's not about kind of putting the onus on, syringe service programs to change, or independently go out, but a way to think about, as a system of care, how can these relationships and what are the examples out there that are doing that. It also sort of affects support for harm reduction that, just to share a little bit more of the data that's out there. I know we have at least one person joining from Michigan, but, some states are kind of mandating reporting of data on, a variety of metrics, and one is treatment referrals. As far as I can tell, there aren't as many states doing that, but, here are just some examples from Michigan that, in the third quarter of 2022, they had about a little over 17,000 clients served and made 1,000 treatment referrals in that time. So this data doesn't really talk about what that means, how those referrals are set up. I am going to show an example from Michigan that, it is one pretty new model. But just thinking, here's another example of, that comes out of Utah. And, you can kind of see that they require referral as part of each encounter for all providers, now whether that's the best approach, if it's just something that's going to be a rote recommendation or a piece of paper handed when someone comes to pick up supplies, rather than something that happens maybe less frequently, engaging people who express a motivation or a desire for additional services. Here they kind of distinguish between written, verbal, and active warm handoff referrals. So, I'm still kind of looking at data and kind of trying to gather examples, but this is, 2 states that are doing that. So here's a place, many of you maybe have heard of. It's, one of a number of, harm reduction providers I've spent time with. This is in the Kensington neighborhood of Philadelphia that gets a lot of coverage. And, they do offer treatment through this, so this kind of slide talks about, that they've expanded in the time that they've been around to do case management, medical care, overdose prevention education, medication-assisted treatment, and naloxone distribution. They offer mail services, which is one way that people kind of maybe sometimes first interact with Prevention Point. And then as they build relationships, the kind of things Kelly was talking about, they might express interest in, other services that are there. But, it is a really much more holistic and, certainly depends on the resources an organization has, but, their approach is grounded in a very harm reduction approach, while recognizing that, to be a hub for kind of broader set of services can serve their participants. So this is, the program, that's specifically related to kind of this topic of treatment is their stabilization, treatment, and engagement program. It's a medication-assisted recovery program. It's initiated in their office. You know, they most commonly prescribed medications are naloxone injections and buprenorphine. It can be, they do referrals to methadone, inpatient, and other treatment options. And, you know, for the fiscal year ending last June, they had 401 participants, which was a 32% increase over the previous year. So, you know, in the conversations I've been having, it's been interesting to hear, you know, and see different models of how this kind of treatment pathway can be happening. You know, they work with a care manager there. They're certified recovery specialists, and, you know, they can help people get to other behavioral and mental health appointments, but actually have treatment rooms on sites. You know, obviously that's a bigger facility than many places are able to offer. But, you know, as this slide points out, they ask how the program can better fit individual recovery needs rather than how individuals can fit the program. You know, they are low barrier, don't require ID, don't require insurance at intake. They have the transportation support and, you know, flexible appointment times. So, you know, importantly, have also said, you know, there's, if someone relapses, there's no judgment. You know, so, you know, that's something that the executive director of the organization had said to me has changed over time. So we'll talk about that more shortly. This is another newer example in Michigan. Some of you may be familiar with the RED project. This was also a place that I was able to visit and spend time with in a couple of their locations. This is the flyer, you know, on the left that they had put up. They recently started a program to initiate medications for opioid use disorder at their office. And they really are using it as a pilot because they have recognized the need for this service in rural counties near Grand Rapids, Michigan. So they do already own a van and kind of want to be able to bring treatment to people who don't necessarily live close to providers. They have a dedicated staff member working on this initiative who is a recovery coach who has personal experience with medications, and they've partnered with a trusted provider, Corewell Health, in the community. And for those of you coming from kind of this background of how did they get funding for this, the funding comes from a state opioid response grant. So, you know, they really wanted to make it low barrier, so spent a lot of time kind of designing something that, you know, participants don't need an appointment for an initial visit. You know, they can arrange for the first visit to be conducted with a provider via telehealth right from their office. You know, the provider will then help navigate insurance coverage. They sought out toxicology testing that they could do at their office using oral swabs. So, you know, that was really important to them. You know, they didn't want to get involved in kind of doing the urine testing, but more importantly, too, they want to be able to use this in their mobile unit where that wouldn't be an option. So, you know, abstinence not being required for treatment was also important. So they had said that they really, the interest in this was, you know, a lot more than they had expected as an organization. And, you know, so they are just kind of getting it off the ground and kind of looking to expand it. But, you know, it's been a lot of learning for them that they, you know, had kind of thought that because there's so many providers of buprenorphine in the community that, you know, it was more important to really focus on people who live further away. But what they found is that people, you know, being able to create, you know, what the recovery coach there told me was the warmest of warm handoffs. You know, she mentioned that when she first considered treatment, you know, she might have thought about it 100 times, and just, it was so daunting that not having, it took a lot to get over those hurdles kind of internally and externally to get it. So their program is really focused on this idea of taking away barriers. So, you know, I think is one that's been interesting for me to follow, having kind of been there and kind of seeing what they offer. Any other questions or any questions on those examples? So I, you know, wanted to focus on SSPs because that was an area I'd kind of gone down that path and spent time with. But, you know, if we think about harm reduction more broadly as sort of a set of strategies or a philosophy, you know, and the fact that there are a limited number of, you know, organizational providers with physical locations around the country, doing syringe service programs. These are kind of examples of other places that taking a harm reduction approach can be a bridge to treatment. Law enforcement, specifically deflection initiatives, which are distinguished from diversion initiatives in that they really kind of try to, or that they do make that kind of deflection happen before anyone is arrested or has any criminal justice involvement that can saddle someone with a record. So, that's one way that people can kind of, find that pathway between a harm reduction approach of not entering the legal system and getting treatment. Many of you might be familiar with post-overdose response teams operating in different areas that go out and, talk to people after they've experienced an overdose. Another way that kind of reducing harm can be a bridge to treatment for people, areas that have those resources and people who express interest in that. Supportive housing services, programs in schools and universities, emergency services, mobile treatment units. So, really this is a list that could be expanded on and kind of presented in more detail, but, just wanted to kind of point out that, if we think about harm reduction as an approach, that these are all kind of venues or areas where that could be a pathway to treatment and other services. Any other suggestions I should look into or add to the list? Okay, feel free to add in the chat. Yeah, love the work that LEAP does. Another organization, I should have put it on the slide, is PARI. I'll add that to the chat to kind of look into and maybe sign up for their emails just to see some of the partnerships that they have. Similar to LEAP, but again, this idea of not being diversion, but deflection, so that, it really happens before anyone, has contact with the system. So, kind of switching gears a little bit here, also wanted to talk about ways that treatment providers can kind of incorporate principles of harm reduction into their services. So, just wanted to start with that question of, either in the work you do or, examples that you've seen, how are treatment providers taking more of a harm reduction approach than maybe treatment was 10, 15, 20 years ago? And again, feel free to add in the chat, raise your hand or unmute.
I guess this would have been the part to say that I feel like divesting from abstinence and recovery as being mutually exclusive can only benefit the population.
Yep. That's
also, a lot of people seem to think that harm reduction starts and ends with Narcan, which to me is like so hilariously out of date.
I'm not sure, Kelly, if I caught where you are. I'm sure it's in the chat, but just regionally.
Rochester, New York.
Okay, got it.
I work at Strong Hospital, but I would technically work for Strong Recovery.
Got it. So we did some work up there, my husband and I, so know a little bit more about that. John?
Yeah, congratulations, Kelly. I'm just curious, maybe I don't know where it would kind of fit, but I'm thinking about stigmatizing. And where you have those conversations, because sometimes, as a professional, sometimes you kind of forget when you're in an elevator, you're having a conversation, and sometimes trigger words kind of, because you don't know who in that elevator may be having an issue of a situation. And sometimes those trigger words is just enough for them to go out after all their hard work to go and do something. So it's always that stigmatization that you really have to be conscious of where and who you're having those conversations with.
Yeah, I think that's a great point, that, and that this work can be, really tough, and, particularly during the pandemic, and, people sometimes do let their guard down, but, using, not being aware of kind of where you're being overheard, or just kind of how those attitudes, a lot of the research that's been done on stigma, particularly with healthcare providers within the system more broadly, so ranging from medical residents to, primary care to people working in specialized treatment, that's where a lot of stigma really shows up. Cheryl?
Yes. the OTP program I worked for in Harlem, we right around the corner from On Point, and we have a very good relationship with them. And matter of fact, our patients attend around the corner because they offer an array of services. So some staff, it has become difficult for them to understand harm reduction, and I'm trying my best to have On Point come in and provide the services to let them understand that it's basically where the patient is at. So this has been a great training, and I intend to utilize it for my staff. But one thing I encourage my staff to do, if our patient attend harm reduction, they should look at this as an appealing way of staying safe and keeping alive. And this is what I'm trying to really get the staff to understand, because believe me, stigma exists within the own services that we offer. It exists with our medical staff, it exists with our nurses. So I'm always have to find myself using MI for my own staff. So I appreciate your training. Your training was very helpful, and I intend on utilizing within our program.
Great,
And
thank
thank
you.
you, Kelly. I might have to come have you speak at one of my meetings. Thank you so much.
And feel free to share in the chat too. I mean, this, it's still kind of evolving as a workshop, but, hopefully the slides will be helpful in kind of sparking conversations, and, the workshop will be offered again. So, other people get a chance to take it, and I'm kind of adapting it as I go here. Kelly?
I swear I'm going to shut up soon, but so a training, or not a training, a lecture that we did, myself and another peer specialist here with the University of Rochester, was around stigma, but more importantly around the well-intended stereotypes that happen a lot. Because even with, kind of as what Cheryl was saying, even within the field at large, and even within the recovery community, or the recovering professional community, it's still, take for example, referring to addicts as vulnerable. We're not vulnerable, we're resilient. So referring to us as a vulnerable population can sometimes be that well-intended stereotype, when in fact we should be reinforcing the resilience of this population, the adaptability. And something about like stop the stigma just reinforces that there is a stigma, when in reality nothing about using substances or having a dependence should be viewed as shameful or stigmatizing to begin with. So we got a lot of pushback when we rolled that lecture out, but I think it was because, as can often happen with things like racism, is that it's very subtle, and a lot of the time it comes from a well-intended place where you want to have solidarity, but in fact you're just kind of like compounding the problem. So I did not make a ton of friends at that lecture, but I do think that we opened some minds. Yes, they are very, I guess, vulnerable in the way of like, when you refer to the addict community at large, not that we aren't vulnerable in terms of like crime or trafficking or things like that, but as a person, I don't view myself as a vulnerable person. I choose to view myself as very resilient, and I was very adaptable, and I have a lot of perseverance. And I feel like highlighting and uplifting that, as opposed to framing it as kind of like a vulnerability or a susceptibility or being gullible almost. That's how it always felt to me. I think that there is just a very good balance that can be found in a more, I don't know, but it also, it's like kind of yucky stuff to bring up. It can, cause a lot of difficult feelings.
Yeah, I'm just adding to the chat. So I think, what I've heard that described as, Kelly, is kind of a strength-based approach, kind of even just more broadly within healthcare and public health, so focusing on people's strengths. And it can be difficult, you see, to me, it's about generalization. So, when you hear marginalized or vulnerable, or whole groups that, so I think that's a really great point, and great to be able to have the opportunity to do those lectures. I've met some people who this was also in New Haven, would go into the medical schools and kind of talk about how people felt when they were treated, particularly in emergency rooms or at the hospital, and having a real impact, on residents and kind of the next generation. And that was where there was a really interesting model of people, these street medicine teams were primarily made up of medical residents, who were bringing healthcare services to, parking lots, and developing those relationships, but then also taking it back into, their classmates and kind of talking about these issues. So just some of this has been mentioned, but, here's another, this is something I kind of added this time that I thought was a helpful article to think about. This is more broadly about harm reduction principles for healthcare settings overall. So, not necessarily substance use, but, trying to frame it like that for this slides here. And they came up after doing some interviews of sort of 6 principles here. So humanism, being the first, talking about valuing, caring for, respecting, and dignifying patients. Pragmatism, so supporting a range of goals, not just abstinence or perfection. So perfection being the idea that, if you're working with someone who's has diabetes, that they, might not have a perfect achieving, whatever dietary goals you're discussing. So again, it's substance use, but also kind of some other health behaviors and goals. Individualism is assessing a patient's needs and strengths and kind of discussing a menu of intervention options. So, that kind of gets back to that idea of thinking about a menu. And, if we want to give people choices, that we should at least have more conversations about what a menu looks like and how can we, as Kelly brought up too, focus on what people's strengths are. There is a lot of resilience and creativity and hustle, and, how can that be leveraged through the treatment process? Autonomy, patients making their own choices about medications and treatment options and not being forced into, something just because it's what's offered or what's covered by insurance. Incrementalism, so recognizing any positive change as a step toward improved health, so sometimes heard of this talked about as gradualism too, so that the goals might change over time, but respecting that, each of those goals is a pathway and kind of, again, movement toward, healthier behaviors or lifestyles. Accountability without termination. So patients are responsible for their choices, but not fired from care, so, that's something that's, going to highlight again on another slide. But this is a open access, I'm pretty sure, study. If it's not, email me and I'll send you a copy. But I thought it was an interesting way kind of to think about this topic and break it down into really kind of simple categories. So, this is just a partial list of strategies, but, one that I think and I've heard is shifting that, for treatment providers offering overdose education and naloxone training and treatment settings. I couldn't find research showing how often that's happening, but, just wanted to point out that this is an organization in New Jersey that has kind of worked with some, including inpatient treatment programs to make sure, do trainings on, overdose education and linkage kind of to making sure naloxone is provided. So, feel free to add in the chat because I am curious about how common that is as part of a treatment program. This is a site that came up last week and many of you may know about, but I really highly recommend it. And let me see if I can copy the link here into the chat. If you go to this page with the state finder, they list a range of resources, not just where to get naloxone, but, harm reduction services, treatment finders in different states, really just a range of organizations. It's a helpful resource to know about. And I recommended it to many people. So adopting a more humane approach to toxicology testing. Here's a quote from a treatment provider that primarily does methadone in New York City, saying, "We don't use toxicology in a punitive way. We don't discharge patients for a positive test." This is up in Hudson Valley. We don't go into the bathroom with them. We give them the cup and they go into the bathroom. That's a huge shift, not having them be observed. It's part of harm reduction and also recognizing that this is a trauma-informed facility. We're also moving towards the swabs. Not requiring abstinence in order to receive treatment. So again, a couple quotes from people that I talked to, and if you have other examples, please add them in the chat, or feel free to comment. Abstinence is not the goal that is pushed. Oftentimes motivational interviewing is used to work with patients to set their goals and develop treatment plans. 25 years ago, if you used in treatment, you would drop that day. Now what we say is, if you use, just be honest and we'll assist you. We view it as a treatment issue that needs to be addressed. So that's a big change. So these are just kind of a couple examples. It's trying to get a handle on kind of the wider treatment landscape, is challenging, and, welcome any suggestions kind of on research, or if you've come across it, or examples of, treatment providers that have evolved in terms of some of their approaches. Avoiding practices that humiliate and punish participants. So Kelly brought this up. Definitely was an experience that my husband had, through his trajectory, particularly having been someone with a lot of criminal justice involvement. This article I thought was really good to kind of help kind of understanding just this idea of policing, if you've had that experience, and some of the rules that kind of come up within treatment settings, that, small relapses can send you to jail, and kind of how that intersects with, systemic racism and racism in general, and then other populations where, people have a range of experiences and bring those into the treatment setting that are not always recognized and kind of adapted to in terms of kind of trauma-informed care and kind of more culturally sensitive care. This is also another article, just in case this doesn't make it through the slides, kind of looking at treatment access, from that a range of kind of, unequal access to treatment, which is getting a little bit more attention as well, for, kind of what populations and what parts of the country is treatment more accessible. Any thoughts? This is kind of a partial list, so, curious to hear about other ways that you either have seen or, would hope that treatment could be evolving to kind of embrace more of a harm reduction approach. Yeah, Carlos has added in the chat here, harm reduction originally emphasized the decision of each person. Traditional programs focus on shoulds and musts. So this idea of kind of using that idea of you should or you must do something, tends to not work very well in any kind of treatment setting there. Handing out kits, we were facing the possibility of being arrested. This is still going on. Carlos, if you could add, I'm curious what part of the country you're in.
We had a underground, unsanctioned, safe injection facility site that was in an abandoned house that people in the field risked their certifications for. And it was stocked. Somebody bought a bunch of needles on Amazon. Somebody else bought a bunch of testing strips on DanceSafe. Everybody had Narcan, everybody had gloves, there was sterile water, and we were basically just reversing overdoses and allowing people to use safely and sit for 15 minutes to make sure that they didn't overdose. And the fact that that's definitely a felony, Carlos, it's exactly the same way around here. The grassroots organizations that go out and we do sharps cleanup, sharp handouts, all of that stuff, we're way more likely to pick up some arbitrary violation or misdemeanor or something like that. I've been arrested 3 times since I started doing street level outreach work for helping.
Okay, thanks, Kelly. Have you seen any changes kind of in your community and sort of within treatment settings of the approach?
Well, they had their hands full hiring me because I am very outspoken about safe consumption and harm reduction, and I have pushed a lot of buttons when it comes to like what is harm reduction and what is just simply best practice. Because a lot of things are considered harm reduction, but in reality, they're just best practice, either medically or clinically. You know, Narcan, that's best practice. Now, syringe exchange, that's harm reduction. So I've been doing a lot of educating around here, but recently we've had a lot of, there's this group called Local New York. I know some of my people down in the boroughs might be familiar with Local New York. There was a big press conference here a while ago that I was honored to speak at about repealing the crack house statute and allowing safe consumption sites in New York City proper. That's where I work with them up here. They also do a lot of like equitable health, health equity and health literacy in some of these more redlined areas. We've gotten a lot better with resource mapping, but a lot of it is that people in recovery we just got fed up with watching our friends die. So a lot of us like flooded the field and got our certifications or became CASACs or became LMSWs and started doing the work ourselves because nobody was offering us a seat at the table. And there's even been a huge reconciliation of internalized bias with employing proudly recovering people. I tell everyone I'm an IV drug user in recovery. I'm damn proud of it. And you know, there's not much about my story that brings me shame, and you're certainly not going to shame me with something I shared with you. So I think that people coming to the knowledge that there is a lot of inherent bias against, especially IV drug users, but users who are in recovery and are now being viewed professionally as excellent resources, as educators. You know, I dropped out of community college after like 3 months because I didn't want to waste my time doing school when I could be using drugs. So, you know, a lot of sort of this hierarchy in clinical settings, medical settings, just in higher education institutions, has been really essential in allowing people like myself and like the wonderful recovering professionals that I train and work with all of the time, allowing us into these arenas. There's no better teacher than experience. You know, I could go all the way straight through, get my PhD, and I would still probably have learned more from my 10 years on the streets using and fighting for recovery and building recovery capital. Yeah, maybe I'll learn more about biology, but I don't really care about that much. So there's a lot of like good education, hierarchy breakdown, less squeamishness, I guess. Some harm reduction stuff makes people really like, you know, Narcan's okay, but handing out clean syringes, that's enabling. And it's not.
Yeah, I mean, I'd be curious to hear too that, you know, there's always been this kind of balance between, you know, if you look historically between, you know, kind of that lived experience as part of, you know, what's broadly considered treatment or help for people with substance use challenges versus kind of what's more lately become kind of, you know, thinking back that insurance didn't even cover, you know, most treatment until very recently. So, you know, finding that balance and kind of seeing peers being brought into this more, but often, you know, in some areas in kind of a token way, or, you know, requiring a lot of kind of that the process to get that sort of certification is not necessarily as accessible as it could be.
I think one of the biggest things that happened was that OASIS, the governing body in New York, they made it mandatory for a peer to be in every facility that is OASIS certified. That was a big deal for us in New York State.
Okay. I wasn't aware of that. I didn't realize OASIS had done that. So thank you for sharing that. Carol?
I would go one step further in terms of who needs to be at the table. There are a lot of people who know how to use drugs successfully and are still actively using, and they are not at the table. They could teach us so much. I get frustrated because when I go to meetings that focus around substance use or harm reduction, the people at the table are often people in recovery, but certainly not coming from the point of view or the strength that Kelly is expressing. I do know vocal very well. Know a lot of people in there, but it's still, we always go to, they have to be in recovery. And there are a lot of people who are living their best lives and still using and need to have their voices heard.
I think, I mean, there are definitely some examples where I've seen of people, you know, particularly the Users Union out of North Carolina, that kind of is that role and working with researchers there. So I have seen more examples of that, and
Very limited though.
Certainly, you know, limited. I think that gets into a little bit more of a policy discussion, you know, so just kind of bringing it back to, you know, treatment settings and what people have seen or would like to see as far as, you know, changes to how treatment is offered, or how we can kind of bridge this harm reduction and treatment and kind of not have, you know, things be in silos where, you know, we're not thinking about, you know, or not as much emphasis on the continuum of care. Jason has been quiet, but as part of this workshop today, and, you know, appreciate some of what he's posted kind of coming out of treatment in Michigan, you know, for many years, and, you know, recommend that blog with the link there, which again, you'll get the slides. But, you know, a phrase that I had started hearing a little bit more was recovery-oriented harm reduction. So I've summarized a lot of what he's written on this topic, and Jason, feel free to kind of chime in or add anything. Hopefully I'm accurately representing, but, you know, thinking about it as, you know, trying to bridge recovery and harm reduction as a way of kind of addressing the historical failings of both abstinence-oriented treatment and harm reduction services. You know, so, you know, we've all kind of talked over the last couple sessions about how these things can kind of be in separate arenas, and kind of how, you know, as with anything, you know, there's room for improvement. So how can we bridge over, you know, some of the divides that are happening? Recognizes that addiction harms individuals, families, and communities. So, you know, that relates to, you know, that quote that I shared last week, you know, really thinking about if, you know, you made a whole list of harms, you know, particularly of addiction, that, you know, there's a subset that's getting addressed through what are kind of traditionally known as harm reduction strategies, but also a lot of other harms that families and communities, you know, want to see addressed and are advocating for as well. So, you know, making sure that they're not left out of the conversation about kind of how can we reduce harm and promote, you know, recovery, again, broadly defined. Is committed to improving the well-being of all people with addictions, and believes that recovery is possible for anyone. So, you know, really not writing anyone off, you know, that maintaining that hope and believing in the possibility, and kind of what Kelly pointed out, you know, the strength of people, you know, regardless of their circumstances. Emphasizes client choice, not coercion, you know, respects voluntary engagement with services. So, you know, historically, a lot of people do have negative feelings about treatment. You know, some of it has to do with having a for-profit system or treatment systems that kind of were very tied in with, you know, corrections and the legal system. But, you know, thinking about how can that be improved, you know, especially as, you know, there's more need, more interest, and how can this be something that people are able to decide, you know, and then change their mind and decide on something else. Supports incremental and radical change, you know, it embraces partial and serial recovery, but seeks to be a bridge to full recovery. So, you know, again, this isn't utilizing the word abstinence, but, you know, we could have a whole other workshop on different ways to define recovery. But really thinking about that sometimes change does happen incrementally and other times it does happen kind of more radically, but respecting both of those pathways and, you know, partial and serial recovery, you know, thinking about those goals that we talked about, that, you know, someone's goal might be to quit using or quit one substance or quit injecting, but, you know, over time that might change or it might not. But, you know, always kind of keeping in mind that, you know, this is trying to be a bridge to, you know, supporting people in achieving the goals that they identify. Jason, I hope I've done that justice. Is there anything you want to add? If you're able to, I'll look out in the chat as well. No thanks. So, you know, just wrapping up here, you know, I appreciate everybody joining. Hopefully you were able to be here for both sessions. You know, really, this is just an effort to kind of start a conversation or participate in one that's probably happening in other places about, you know, kind of thinking of ways to kind of support and strengthen this connective tissue or these bridges.